Okay. So today we're going to discuss valvular heart disease. So we will. So starting with this case over here. So we've kind of gone through this before, how to name the valves. So which valve is this? Right? We're doing NJMS first. So the aortic valve, this is this one.
Mitral?
And
tricuspid.
right. So we said that to name the valves on the lateral view, we draw a line from the bifurcation of the airway anterior here to the anterior costophrenic angle. We look in the middle of the heart. Just anterior to that line is the region of the aortic valve, and just posterior to that line would be the mitral valve. Notice the aortic mitral valves are close together. The tricuspid valve is the most inferior valve, and so the pulmonic valve would be where? Superior and anterior, right. So that would be up there. So those are the valve positions. A little bit harder to tell on the frontal view to separate the aortic and the mitral valve, but the tricuspid valve is still the most inferior and the pulmonic valve is still the most superior. Okay. So over at St. Barnabas, if we look at this X-ray, we have a frontal and lateral view. What are the findings? And if there's a valve problem here, what valve problem would that be? Anything? Well, you guys. Yeah, so the ascending aorta here, you can see is tortuous or dilated, but on the lateral view, it does appear dilated, okay? So is there anything else we see on the lateral view? If we look right there in the middle of the heart, what is this stuff? Yeah, that's aortic valve calcification. So what would be the valve problem that would give you then this dilatation of the ascending aorta? This person's problem would be what? Aortic stenosis, right, and then that's poststenotic dilatation there of the ascending aorta. So you have the dilated aorta, the aortic valve calcification. Even on the frontal view, we can see the tortuosity there, or dilatation of the ascending aorta. So if we look on this CT scan, if it's the same patient here, what's this patient's problem?
Bicuspid.
Yeah, so we have extensive aortic valve calcification, as we saw in the plain film, but it's also a bicuspid aortic valve. Notice that it's when the valve opens, you can see that bicuspid morphology. So that is a bicuspid aortic valve leading to the aortic valve calcification and the aortic stenosis. So when we're looking at the bicuspid valve, it's best to look at it during systole when the valve is open. When the valve is closed, it's very difficult to tell the morphology of the valve. So these are MR images going through the plane of the valve. It's when the valve is open that you can tell that there's bicuspid morphology to the valve. Now, there's something else that can also be associated with bicuspid aortic valve, and it's demonstrated there on the second image, and that something else is what? Coarctation of the aorta, right. So now, most patients with coarctation, so the association goes this way, about 70% of patients with coarctation will have bicuspid aortic valve. So bicuspid aortic valve doesn't mean you have coarctation, but it goes the other way. So about 70% of patients with coarctation will have bicuspid aortic valve. So if you make a diagnosis of a coarctation, take a very good look at the aortic valve, because most of those patients will have a bicuspid aortic valve. So we'll talk about here the anatomic classification. We'll talk about the different causes of aortic stenosis, whether it's valvular, subvalvular, or supravalvular, and we'll discuss the radiological manifestations. So over at St. Barnabas, what is the most common cause of valvular aortic stenosis in the United States? What is the most common cause? The atherosclerotic disease of a tricuspid aortic valve is the most common cause in the elderly. So age-related degeneration of a tricuspid valve, and the bicuspid valve comes in second, and then rheumatic heart disease comes in third, although with rheumatic heart disease, when there's aortic valvular stenosis, you usually also have involvement of the mitral valve. Now, not that I need you to memorize these numbers, but the point is the severity of stenosis is correlated with the valve area. These are measurements that they would take on echocardiography and measurements that we can also do on imaging. So these are the measurements that are associated with the various degrees of aortic stenosis. So we know about the symptoms: chest pain, syncope, CHF, even sudden death. And aortic stenosis does predispose to endocarditis, which can further destroy the aortic valve and lead to aortic regurgitation. So valvular aortic stenosis in the younger patients, you want to think about bicuspid aortic valve. So those are young patients who develop aortic stenosis. Bicuspid valve is the most common congenital cardiac malformation, and it's present in about 0.5 to 2% of the population. Rheumatic heart disease in kind of that middle age group, so this can also cause aortic stenosis, although in these patients, remember, rheumatic heart disease preferentially involves the mitral valve. So in many of these patients, the mitral valve is also involved. But the most common cause in the United States is just atherosclerotic degeneration of a tricuspid aortic valve in the elderly patients. So the normal aortic valve is tricuspid. When you have bicuspid morphology of the aortic valve, that leads to the abnormal hemodynamics of the blood flow through there, which can result in damage. So this is what a normal aortic tricuspid aortic valve looks like when it's closed and when it's open. And here it is on a cardiac gated CT. You can see you have all three cusps there, and when it opens up, it opens very nicely, okay? And this is a bicuspid valve with the stenosis thickening, and it's the pathologic specimen here. And here's a radiograph of the pathologic specimen showing you the calcifications that can occur on this bicuspid aortic valve. So calcifications on a valve, if we see it on radiography, always means aortic stenosis. All right, so for you guys over here, these are three different types of bicuspid aortic valve. So who's taking the boards this year? Right over there. Okay, good. So this is a pure bicuspid aortic valve, okay? So here, which cusps are fused?
Right and left?
Yeah, right and left. So the anatomic landmark for the posterior cusp is the interatrial septum. So you find that in the cusp that's closest to that is the posterior non-coronary cusp. This is the right cusp, this left cusp. So that's fusion of the right and left. And here we labeled and we've been nice to you on this one. So the cusps that are fused are?
Non-coronary and
Yeah,
right.
the posterior or non-coronary and the right. Now, which of these variants of bicuspid aortic valve is the most common?
B. Right.
Correct. Right. So a pure bicuspid valve, that pure bicuspid valve morphology is actually quite unusual. Fusion of the right and left cusps, this one, that's about 70% of bicuspid aortic valves. That can also be seen in patients with aortic coarctation. Fusion of the right and the non-coronary cusp, so that one over here, that's the second most common. That can also lead to, of course, aortic stenosis. Well, what's left? Fusion of the left and the non-coronary cusp, but that one is actually quite unusual. So that one's only 1.4% of cases. So fusion of the right and left coronary cusp, that is the most common variant of bicuspid aortic valve. So here's a cardiac gated CT showing you a pure bicuspid aortic valve, right? So that morphology is actually quite unusual to see a pure bicuspid aortic valve like that. And then this one here, we have fusion of the right and left cusps here, okay? Over there, here's the left atrium, right atrium. Here's the posterior cusp, that's the right and left cusp there that are fused, heavily calcified. Another example of aortic stenosis there on CT. Now with aortic stenosis, you can also get post-stenotic dilatation of the ascending aorta. So here's a nice kind of volume rendered image of a bicuspid valve with some calcification, and there's post-stenotic dilatation of the ascending aorta. And these patients are at increased risk for aortic dissection because of the aortic dilatation. Okay, so over at St. Barnabas, this is a young patient with severe aortic stenosis. So you can see on the CT, we've got a dilated left ventricle, left atrium's on the big side, heavy calcifications of the aortic valve. Very young patient. So what abnormality might account for this? If we have a very young patient with severe aortic stenosis, what do we think about? Any ideas? Well, bicuspid aortic valve, sure, but this patient is even younger than that age group. Rheumatic heart disease, again, that's usually an older age group and usually also affects the mitral valve. You guys over here?
Either hokum or
Well, it's not hokum. Hokum doesn't give you calcification of the
One
aortic
valve?
valve. Plus, I told you up there, he has severe aortic stenosis.
So like a
So one
single
unicuspid valve, right. So in younger patients, you think about more morphologic abnormalities of the aortic valve, and actually even in children, so this tends to affect children actually, a unicuspid aortic valve where they have just one cusp with a narrow opening in there in the center of the valve. So this leads to severe aortic valvular stenosis in a younger age group, all right? So these are the various aortic valve morphologies that you can see. So we've talked about bicuspid valve, we talked about unicuspid valve, we talked about the various morphologic forms of bicuspid aortic valves. We've kind of gone through all that. Radiology, if there's calcification of the aortic valve, that always means aortic stenosis on a radiograph. Remember, CT is more sensitive for calcification. So if we see calcification on CT, the heavier the calcification, the more likely there is and the more severe there is aortic stenosis. But just a little bit of calcification on the aortic valve on CT does not mean that the patient will have aortic stenosis. Okay? Heart size is usually normal until there's decompensation, and then the left ventricle will dilate, although you will get hypertrophy of the left ventricle. And you can't see doming of a thickened aortic valve on angiography. So calcification of the aortic valve on the plain film always means aortic valvular stenosis, post-stenotic dilatation there on the plain film of the aortic valve. On angiography, here's a nice post-stenotic dilatation. You can see there's thickening of the valve here, and there's some doming of the valve as it is not opening all the way. So those are findings that we might see on angio. So it's a mild aortic stenosis here. It's a tricuspid valve. You can see there's some aortic valve calcification. It's opening, but it's not opening all the way. So that's mild aortic stenosis. Again, you would take measurements of the aortic valve area when it is completely open, and you would match that up with your chart to kind of grade the severity of the aortic stenosis. Here's an example of severe aortic stenosis. Again, calcification, thickened leaflets. Again, it looks like a tricuspid valve here morphologically. But notice that during systole, the valve does not open completely, and if you were going to take the area of that, it would be quite small, probably significantly less than 1 square centimeter. Right? So that's an example of severe aortic stenosis. And then here we're looking at it on coronal view, and again you can see the valve is not opening all the way, the valve is thickened and calcified. All right, so those are features of aortic stenosis on CT. Here's another CT showing you this pure bicuspid morphology of the aortic valve. This one is not so stenosed, not much narrowing there in that, for that example, for the bicuspid aortic valve. Okay, so over here, you guys, let's look at this. We're looking at kind of 3 different views here. What kind of view is this? This is a left ventricular outflow. This one, kind of a 4-chamber-ish, right? This one, it's kind of a coronal view through the ascending aorta, all right? So when we look at this, is there a flow disturbance?
Yes.
Yes. During what phase?
Systole.
Systole, right. You can see it during systole. Here's the aortic valve, and we see the flow disturbance. Now, at what level does the flow disturbance begin? Below the aortic valve, right. This flow disturbance is not beginning at the aortic valve. This flow disturbance is starting below the aortic valve. So what do you think the cause is then in this patient?
Below the valve stenosis.
What do we call that? Well, what do you think the problem is?
Hypertrophic cardiomyopathy?
Does that look hypertrophy?
No.
No.
Oh,
So and actually you can see it. Look very carefully, right? You can see that little
membrane?
Yeah, there's a membrane. This is a subvalvular membrane. All right, this is a very rare cause of aortic stenosis. This is a cause of subvalvular aortic stenosis. Okay. Now here's a kind of a companion case. So over at St. Barnabas, Do we see the flow disturbance here on this left ventricular outflow tract view? Yes? So what's the diagnosis here? This is HOCM. You can see the extensive hypertrophy in the outflow tract, the flow disturbance beginning below the aortic valve. Here's the aortic valve. So there's obstruction of the outflow tract of the left ventricle. That is HOCM. By the way, there's a bonus finding on that case in this person with HOCM. What's the bonus finding?
Wraparound artifact.
No,
What's that? What's that bulge?
that's a stomach.
Oh.
A
Nothing.
little bit of knowledge, dangerous, dangerous. All right, the bonus, what's the bonus finding associated with HOCM? Who's taking the boards this year? Come on. Is there another flow disturbance? Look carefully.
Mitral regurg?
Mitral regurg. There's a little flash. See that little flash of mitral regurg? Right? That is associated with HOCM. What is it called?
Hypertrophy.
SAM, systolic anterior motion of anterior leaflet of the mitral valve. So mitral regurg is also associated with HOCM. It occurs from the high velocity flow here sucks the anterior leaflet of the mitral valve into the outflow tract, which can lead to mitral regurg. All right. So mitral regurg can also be seen associated with hypertrophic obstructive
Is the
cardiomyopathy.
free wall supposed to be like outpouching like that? Of
Where?
the left ventricle?
No, that's not the
No,
free
the
wall.
other
That's
side. Yeah,
pericardium.
that, like right there.
Here?
Yeah.
No, it's not. I mean, it's not outpouching. Look, it's contracting inward. See?
Okay.
So in systole, if there's dyskinesia, it should go out. This
Okay.
is still contracting inward, right? So you're just partial volume averaging a thinner portion.
Okay.
All right. So that was HOCM. So subvalvular stenosis, membranous subvalvular stenosis, and hypertrophic cardiomyopathy. Membranous subvalvular stenosis, pretty rare. That can lead to a jet, though, that might damage the aortic valve, which means that sometimes these patients might also develop aortic insufficiency in addition to aortic stenosis. Here's your subvalvular membrane there on this angio, and then here you can see it here too. Okay? And then that was the example that we saw here. So the flow disturbance starts below the level of the aortic valve, and here you can actually see the membrane going across. There's no hypertrophy, right, to say that this was hypertrophic cardiomyopathy. So in this case, that was a subvalvular membrane. And then here's another example, nice, you can see it a little better on this CT. There's the subvalvular membrane going across, and here it is on this volume rendered view. There it is partially, okay? So that can give you subvalvular aortic stenosis. Now, hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy when you have subaortic stenosis, so there's narrowing here because of hypertrophy along the interventricular septum, along the outflow tract. So we will see the flow disturbance in systole, and then as we've said, these patients can sometimes have some mitral regurg from systolic anterior motion of the anterior leaflet of the mitral valve. That is called SAM, or the abbreviation for that is SAM. Okay, so over at St. Barnabas, what's wrong in this case? Supravalvular aortic stenosis, right. So now we have this narrowing of the aorta above the level of the aortic valve. This can also result in some dilatation of the proximal coronary arteries because of the high pressure flow that will be going through there. So that is supravalvular aortic stenosis. So this can be associated with what syndrome? Anybody? Williams syndrome. Williams syndrome. All right, supravalvular aortic stenosis. So here we have stenosis above the level of the aortic valve. Again, this is unusual. So maybe part of Williams syndrome. Williams syndrome is called infantile hypercalcemia. So the hypercalcemia often faces mental retardation, and it can also have pulmonary artery branch stenosis. So here's the narrowing of the supravalvular portion of the aorta in this case. And they can have stenosis with Williams syndrome in other locations also. So you can see the supravalvular stenosis here, and this patient also has stenosis involving the pulmonary arteries. So that's what we can see with Williams syndrome, dilated sinuses of Valsalva and coronary arteries because of the high pressure. So that you might also see with this. So supravalvular, another example of supravalvular aortic stenosis. So narrowing of the aorta above the level of the aortic valve. Okay. If I tell you this patient has a valvular lesion, what valvular lesion might we suspect here? So what are the findings on the chest radiograph? You guys here? What's abnormal on the chest radiograph?
Dilated.
So, well, what's dilated
Thoracic
here?
aorta?
Yeah, the thoracic aorta is dilated and tortuous, right? Or at least tortuous. What chamber is enlarged?
Left
Yeah,
atrium.
no, not the left atrium, the left ventricle, right? So if we have a tortuous thoracic aorta with left ventricular enlargement, what valvular lesion would we consider then?
Aortic regurg.
Aortic regurgitation, right? So aortic regurgitation with a tortuous aorta and an enlarged left ventricle. All right, so here on CT, we're looking at the aortic valve in diastole here on the plane through the valve, and then here on a left ventricular outflow tract view. What is wrong with the aortic valve?
Not completely.
It is not completely closing, right? So that's how, remember, on CT, we don't see jets. So how could we diagnose? So for stenosis, we said, we look to see of the narrowing during systole, but for regurgitation, it should close completely at diastole. If there's still an opening in the aortic valve there in diastole, then the patient has aortic valvular regurgitation. Okay, so the normal aortic valve on CT, if we have these nice images in diastole, should be completely closed, opens up normally at systole. But if there's any opening of the aortic valve on your diastolic images or your images at end diastole, then you worry about aortic valve regurgitation. So here, there's opening in the aortic valve, so we would worry about aortic valve regurgitation. So on CT, we can see that the aortic valve does not close all the way, and the left ventricle is also dilated. So those are features of aortic valve regurgitation. Okay, and this person also has this dilated ascending aorta here, and you can see that the aortic valve is not completely closing. Another example of aortic valve regurgitation. Now, this is another abnormality that commonly is associated with aortic valve regurgitation. What is this patient's problem? St. Barnabas, what is this patient's problem? Well, the aorta is dilated here down to the aortic root, right? So what's the underlying problem here? What is this sign called? Tulip bulb sign. So the patient's problem is annuloaortic ectasia, which is associated with what syndrome? Marfan syndrome, right. So cystic myelonecrosis, which can lead to annuloaortic ectasia, dilatation of the aorta down to the aortic root and the sinuses of Valsalva. So that dilatation can also result in aortic regurgitation. So we can see this in patients with Marfan syndrome. So here you can see in this MR, the dilated aorta coming all the way down to the aortic root, and then here we see the jet going back into the left ventricle in this patient with aortic valve regurgitation. So the causes of aortic valve regurgitation, bicuspid valve in addition to stenosis can also cause aortic valve regurgitation, rheumatic heart disease, endocarditis, traumatic rupture of the aortic valve, so trauma of course can also do it. Dilatation of the ascending aorta can also give you aortic valve regurgitation, and here are some various causes, Marfan's of course, and vasculitis can also give you dilatation sometimes of the aorta. All right, so those are causes of aortic valve regurg. Aortic root dilatation turns out to be a very common cause of aortic valve regurg. The second most common cause is bicuspid aortic valve. Okay? So with aortic insufficiency, that does give you a dilated left ventricle. So we can see that on the plain film. You can get dilatation of the thoracic aorta, both the ascending and descending thoracic aorta with aortic valve regurgitation. So dilated left ventricle, dilatation of the ascending and descending aorta, so we can see that with aortic regurg. Be careful because systemic hypertension might give you similar findings with dilatation of the aorta and later on also left ventricular dilatation. So that might mimic the appearance of aortic regurg, especially if the left ventricle is dilated. So young patient who has a dilatation of the aorta or tortuosity of the aorta there, So in a young patient, you might worry about systemic hypertension, all right? So the bigger the left ventricle gets early on, then the more you would worry about more severe aortic valve regurgitation, since the left ventricle doesn't dilate until later on when there's decompensation in patients with hypertension. So there's that patient with the thickening of the left ventricle with systemic hypertension, okay? All right, so you guys over here, what are we looking at?
Outflow tract?
Yeah, outflow tract view, cardiac gated CT. What's wrong with the aortic valve?
There's some junk on it.
What do you think that junk is?
Vegetable?
Vegetations, right. So your differential for junk on the aortic valve, right? Blood clot, don't forget about blood clot, it's a common cause, but also vegetation. So if the patient has any signs of infection, then you're going to be worrying about vegetations. Vegetations, endocarditis, that can also damage the aortic valve, and you can see that it's not closing all the way, and of course that can also lead to aortic valve regurgitation, okay? St. Barnabas, what's wrong with this aortic valve? What do you call that? Quadrigeminal. You're in the wrong system, buddy. Quadricuspid. This is a quadricuspid aortic valve, and the complication of quadricuspid aortic valve is what? Aortic regurgitation, right. So this is associated with aortic regurgitation. What congenital heart disease is associated with quadricuspid aortic valve? Correct. It's truncus arteriosus is the correct answer. So quadricuspid aortic valve, very rare, but you have four cusps, and it does lead to aortic regurgitation, and it is associated with truncus arteriosus. Okay. So you guys over here, we're looking at what kind of view is this? Short axis, right? And this guy over here is outflow tract. What is wrong?
Yeah.
Yeah, so you're looking here at the mitral valve now. So that is a markedly thickened mitral valve with calcification. And you can see here also that the mitral valve is not opening all the way, right? So this is a patient with mitral stenosis. Also notice that the left atrium is dilated. What do you think the underlying disease is here in this patient then? Rheumatic heart disease, right. This particular deformation of the anterior leaflet of the mitral valve has a name. Season just started.
Football sign.
No. That season started a month ago. Hockey stick. This is a hockey stick deformity of the anterior leaflet of the mitral valve. So that is associated with rheumatic heart disease and mitral stenosis, right? So they're hockey stick deformity. The findings on chest x-ray, you want to be able to notice it right away when you look at a chest x-ray for rheumatic heart disease. So what's the finding on the chest x-ray you want to notice? Left atrial enlargement, right. Look at the three bumps. 1, 2, 3. The first bump is aorta, the second, main pulmonary artery, the third, left atrial appendage. Notice the bump in the left atrial appendage. So when you see that, you start thinking about the left atrium. The left atrium here is dilated on the lateral view, right? Double density, very subtle in this case, but there it is behind the right atrial border, right? So those are signs of left atrial enlargement. So you would think about problems with the left atrium, rheumatic heart disease, mitral stenosis. Also, atrial fibrillation. Atrial fibrillation can also give you a similar appearance, so that's something else to also consider. So mitral stenosis, usually from rheumatic heart disease. This is the most common cause of mitral stenosis. We get scarring of the leaflets at the commissures. The early lesion is mitral regurgitation. So at first the patients develop mitral valve regurgitation, which then progresses to mitral stenosis over many years. As far as the differential on radiograph, left atrial myxoma from obstruction of the mitral valve can look similar on the chest radiograph, but 99% of cases will be rheumatic heart disease, 1% will be left atrial myxoma. So it's a very rare cause of that. So what happens is, as you get obstruction of the mitral valve, the patient develops left atrial hypertension and then pulmonary venous hypertension. That can get bad and develop pulmonary edema. But the pulmonary venous hypertension can result in pulmonary arterial hypertension. And with that pulmonary arterial hypertension, the right ventricle can fail, pulmonary insufficiency, tricuspid insufficiency, and the pulmonary venous congestion at that point might improve at the expense of systemic venous hypertension. So this can, kind of cascade down and get worse. Symptoms: palpitations, shortness of breath, sometimes hemoptysis. Early mitral stenosis, left atrial enlargement. Advanced mitral stenosis, you'll see left atrial and right ventricular enlargement as the patient starts to develop pulmonary artery hypertension, and then you look for enlargement of the central pulmonary arteries. Calcification of the mitral valve, if you see it on the plain film, always means mitral valve stenosis. Again, CT is much more sensitive, so it doesn't always mean mitral stenosis on CT if you see some calcifications. Now, early mitral stenosis, enlargement here of the left atrial appendage, some enlargement of the left atrium, the lateral view. You can see enlargement of the left atrium, the left lower lobe bronchus here is displaced posteriorly. That is the earliest finding on the chest radiograph of left atrial enlargement, is posterior displacement of the left lower lobe bronchus. More advanced disease, so here you can see the left atrial appendage is pushed out even more. Nice double density here from left atrial enlargement. Notice there's also pulmonary venous hypertension, some signs of vascular redistribution, and a big pulmonary artery. So this patient has also gone on to develop pulmonary artery hypertension as a complication of the rheumatic heart disease and the mitral stenosis. Calcification of the mitral valve, it's actually pretty unusual to see that on the plain film. So here the pulmonary trunk is enlarged, the left atrial appendage is enlarged on the lateral view. You can see the left atrium is enlarged, pushing back on the esophagus, and there is some calcification there of the mitral valve. But if we see that on the plain film, it always means mitral stenosis. So here's a case on CT where we can see some calcification of the mitral valve. Notice that the left atrium here is also dilated because of the mitral stenosis. So this occurs from rheumatic heart disease. Okay, so over here, guys, what is calcified here and what's the significance?
Left atrium.
Yeah, it's the whole left atrial wall here is calcified. What's the significance of that?
AFib?
Yeah, so these patients usually have atrial fibrillation. Again, this is associated with rheumatic heart disease. So they can develop clots there within the left atrium. So calcification of the left atrial wall is associated with rheumatic heart disease, but also associated with atrial fibrillation. So over at St. Barnabas, we look at this case. We have a big heart, big pulmonary artery, some pulmonary vascular congestion. When we look here, we see these nodules at the right lung base. How do we put that together with the appearance of the heart? No, it's not tuberculosis. Remember, we're doing valvular heart disease. Nope. You guys here?
Just like calcification.
These are pulmonary ossifications that can also be seen in long-standing rheumatic heart disease and mitral stenosis. So what happens here is that the pulmonary venous hypertension can result in areas of bleeding within the lung, especially within the lower lungs. They develop some hemosiderosis there that goes on to ossify. So these are pulmonary ossifications associated with long-standing rheumatic heart disease, long-standing mitral stenosis. Okay. All right. So over here, you guys, what valve lesion might give you an X-ray like this? What's the finding on the chest radiograph? So the finding on the chest radiograph is, yes, this is right upper, you're right, yeah, right upper lobe consolidation, which does turn out to be edema, right? Pulmonary edema. So pulmonary edema preferentially in the right upper lobe. What is the story then?
Mitral regurg acute.
From
Papillary muscle.
papillary muscle rupture, right? Patient who has a history of myocardial infarction, a recent infarct who develops papillary muscle rupture, they go into mitral regurgitation, acute mitral regurgitation, which is not well tolerated. So they develop pulmonary edema, and it may be asymmetric. It can be worse on the right side, especially in the right upper lobe, because the jet of mitral regurg is directed towards the right upper lobe pulmonary vein. So various causes of mitral regurgitation: acute mitral regurg, rupture of papillary muscle, rupture of chordae tendineae, which can be infection or trauma. Papillary muscle is usually from ischemia. Chronic mitral regurg, we mentioned rheumatic heart disease. Anything that dilates the left ventricle, though, can also result in mitral regurgitation. Papillary muscle dysfunction from ischemia can also do it. Cardiomyopathy, anything that dilates the left ventricle, dilates the annulus there for the mitral valve, and can also result in mitral insufficiency. Now, the pathophysiology and the appearance depends on the status of the left ventricular myocardium and whether it is acute or chronic. You can have acute mitral regurg with normal myocardium, chronic mitral regurg with normal myocardium, mitral regurg secondary to left ventricular failure from papillary muscle dysfunction in patients with ischemia. So if we have acute mitral regurg with relatively normal myocardium, acute mitral regurg is not well tolerated. Those patients go into pulmonary edema, and it can be worse on the right side. Right? So we'll see this in patients who have infarct who develop rupture of the papillary muscle. So we've discussed this, that right upper lobe consolidation in this case from acute mitral regurg from rupture of the papillary muscle. Now, chronic mitral regurg, especially if the ejection fraction or the left ventricular function is normal, means that there's a lot of blood now that is going into the left atrium, and over time the left atrium goes on to dilate and it can get really big, and that's called giant left atrium. So you can see this in patients who have rheumatic mitral valve regurgitation, chronic mitral valve regurg. So they develop, this density is actually the left atrium that is coming out all the way to the right side. And here on the lateral view, all of this is left atrium. So chronic mitral regurg can result in a dilated left atrium, especially if the left ventricular function is relatively normal. So here's a patient with rheumatic heart disease. You can see this huge left atrium from the mitral regurg in this patient. So here's a chest radiograph. So this density out here is actually left atrium that is coming all the way across. You can see also here the left atrial appendage is dilated in this patient. So the bigger, if we're talking about valve disease, the bigger the left atrium is, the more you're going to be concerned about mitral regurgitation, right? So chronic mitral regurg does result in progressive dilatation of the left atrium. Now, if you have mitral regurg secondary to chronic left ventricular failure, here usually the ejection fraction and the output there from the left ventricle is not very large. So there's not a large amount of blood that's being ejected into the left atrium. So the left atrium doesn't get as large as it gets in those cases of chronic mitral regurg with relatively normal left ventricular function. Right? So those patients will have pulmonary venous hypertension, cephalization, may develop pulmonary edema. All of this, though, is from the left ventricular failure. So the left atrium does not get as enlarged here. The left ventricle is on the big side. Looks like some pulmonary edema there. So these are the manifestations of left heart failure. Okay? All right. St. Barnabas, what valve lesion can look like this? What's abnormal here? Yeah, so the right atrium is dilated, so here you would think about disease affecting the tricuspid valve. So what disease affecting the tricuspid valve then? Tricuspid what? Tricuspid insufficiency, right. That is much more common than tricuspid stenosis, especially acquired diseases of the tricuspid valve usually lead to tricuspid insufficiency. So if I tell you that this is a 23-year-old patient, notice the right atrium is big, the right ventricle is big. We see all of this contrast refluxing down into the IVC and hepatic veins. What would you be thinking about? What might be this patient's underlying problem?
Their mom took lithium.
So leading to what? Yeah, tricuspid valve endocarditis would be the most common thing. What are you getting at?
I can't remember the name, but when the mother takes lithium, there's a name of the condition where the right atrium is really big.
Epstein's. Okay. Well, all right. So you bring up the point. Is this Epstein's? Yes or no? And why not? If it is, or why?
They have a really small right ventricle.
No, Epstein's, they get a
The
dilated.
tricuspid shouldn't the ventricle should be atrialized.
So the septal insertion of the tricuspid valve here is normal, right? In Epstein's, the septal insertion point is displaced towards the apex of the ventricle, right? Here it's normal, it's close
Yeah,
to
right
the
ventricle
septal
is
insertion. Oh, no, the right ventricle is fine.
No, I'm saying in Epstein's.
No, in Epstein's, the right ventricle dilates also.
Oh.
Okay, you're right, but there is an atrialized portion, but the rest of it can also dilate. Okay. All right. So this was tricuspid valve endocarditis. Right. So tricuspid regurg, right ventricular failure, anything that dilates the right ventricle can also lead to tricuspid regurg, IVDA with endocarditis, carcinoid trauma. You mentioned Epstein's, congenital malformation, AV septal defects, persistent fetal circulation. That's actually very unusual, and that we would only see usually in newborns. Okay. So without pulmonary artery hypertension, tricuspid regurg is usually well tolerated, but if the patient has pulmonary artery hypertension causing the tricuspid regurg, that leads to systemic venous congestion and pulmonary oligemia. So that can be worse for the patient, and those patients can also develop a right to left shunt if the foramen ovale is patent because of the elevated pressures there in the right heart, which cause right to left shunting across the patent foramen ovale. Okay. All right. So in this particular case, we have a dilated right atrium, dilated right ventricle here, and there's something abnormal in the liver. How do we put these findings together?
Carcinoid?
Yeah, so this would be carcinoid heart disease leading to what lesion of the tricuspid valve?
Vegetables.
No,
Oh,
not vegetation. No, tricuspid regurg. Right. So carcinoid heart disease can also affect the tricuspid valve. So usually it's when it metastasizes to the liver because the metabolites that are damaging to the valves are metabolized by the liver. So it's not until they get metastases to the liver that these metabolites have access to the right heart. It's also metabolized by the lungs, which is why the left heart valves are not involved. So these patients, carcinoid syndrome with liver metastases, so these serotonin-like metabolites damage the right-sided valves. The patients develop fibrous plaques, adhesions, and so the most common combination is tricuspid regurg and pulmonic stenosis. So the plaques on the tricuspid valve result in tricuspid regurgitation. The plaques on the pulmonic valve result in pulmonic stenosis. So it can be any combination, but the most common combination is tricuspid regurg and pulmonic stenosis. So here's a case where we have poststenotic dilatation of the pulmonary artery, big right atrium from tricuspid regurg. That poststenotic dilatation is from pulmonic stenosis, dilated IVC from tricuspid regurg. So the combination of findings of pulmonic stenosis and tricuspid regurg, then you might consider carcinoid heart disease. Okay. For tricuspid stenosis, it can be acquired from rheumatic heart disease, but those patients usually also have mitral valve disease, and congenital stenosis is actually quite rare for the tricuspid valve. And then, we list some other things that can also affect the tricuspid valve. So again, with tricuspid stenosis, the right atrium would dilate in patients with tricuspid stenosis and systemic venous dilatation as the pressures are elevated there on the right side. Okay, over at St. Barnabas, what's wrong here? So what's wrong with the pulmonary artery? So there's enlargement here of the main pulmonary artery and also of the left pulmonary artery. What do you think of the right pulmonary artery? Yeah, the right pulmonary artery looks normal. So what would you be thinking about in this case? Pulmonary valvular stenosis, right. So this appearance is associated with pulmonary valvular stenosis. So that's usually congenital. So these patients can develop right ventricular enlargement, but they'll get poststenotic dilatation of the main and the left pulmonary artery with a normal right pulmonary artery. That's how you differentiate this from pulmonary hypertension. With pulmonary hypertension, both pulmonary arteries would be dilated, okay? So this occurs because the poststenotic jet affects the main pulmonary artery here, but the left pulmonary artery is continuous with the main pulmonary artery, so it goes on to give poststenotic dilatation of the left in addition to the main. The right pulmonary artery comes off at an angle, so you do not get poststenotic dilatation of the right pulmonary artery. So this appearance of dilatation of the main and the left pulmonary artery with normal right is associated with pulmonary valvular stenosis. So here you can see the thickened pulmonic valve and this poststenotic dilatation there of the main pulmonary artery. Here's a big left pulmonary artery there going over the left upper lobe bronchus here. Okay, there's that left pulmonary artery going up over the left upper lobe bronchus there. Okay. Another example on angio of thickened pulmonary valve leaflets and poststenotic dilatation there of the pulmonary artery. So pulmonary valvular stenosis can be treated with valvuloplasty, so put a balloon in there and try to open up that region of pulmonary valvular stenosis. Now, pulmonary insufficiency, the most common cause is usually pulmonary hypertension. So the pulmonic valve does not tolerate pulmonary hypertension very well. There are other causes, endocarditis, surgery after tetralogy of Fallot, Marfan's, absence of the pulmonic valve, which can also be associated with tetralogy. So here you'll see dilated pulmonary arteries and dilated right ventricle. Because most cases are from pulmonary hypertension, you see the manifestations of the pulmonary hypertension. So you see the big main and the bilateral pulmonary arteries, and there's enlargement here of the right ventricle, but all of that you can see with pulmonary hypertension. And the pulmonary regurgitation can just lead to more dilatation then of the right ventricle. Right? So here's a 41-year-old with a systolic heart murmur. So who sees what the problem is? You guys over here, what's the problem? Quadricuspid what? Pulmonic valve, right. This is a quadricuspid pulmonic valve. And again, that can lead to problems like regurgitation, right? That's a quadricuspid now pulmonic valve. Interestingly, these quadricuspid pulmonic valves can be associated with abnormalities of the aortic valve also, since they kind of form embryologically around the same time. So this can be associated with bicuspid aortic valve. So they can have pulmonary valve dysfunction. They can have either regurg or stenosis with quadricuspid pulmonic valve.
What I'd like to talk about now is MR of valvular disease. So CT is good for spatial resolution, but the temporal resolution of CT is not as good as the temporal resolution of MR. So here we would like to discuss some of the findings of MR associated with valvular disease. So first, we'll start with the aortic valve. So if we want to evaluate the aortic valve with MR, we have to pick a good valve plane exactly through the aortic valve. So from your short axis view at the base of the left ventricle, if we take this prescribed slice, we get a left ventricular outflow tract view here. And then what we will do is try to get a good cross-sectional view of the aortic valve as prescribed on that image. And so that gives you a very nice view of the aortic valve en face, and here the aortic valve is open. So this is an axial plane through the aortic valve. Now, if we take a plane just above the aortic valve, we can evaluate the flow in the ascending aorta. So we want a plane exactly perpendicular to the ascending aorta, just above the aortic valve, and then we can do phase contrast imaging there and look at the flow through this region throughout the cardiac cycle. And if we know the cross-sectional area, which we can measure from these images, the cross-sectional area times the average velocity of flow will give us the flow rate through the ascending aorta just above the aortic valve. Now we can do the same thing for the pulmonary artery. We take a cross-sectional image just through the pulmonary artery, just above the pulmonic valve. And then on our phase contrast images, we can evaluate the flow through the pulmonary artery throughout the cardiac cycle. And again, we can take pulmonary artery flow measurements. Now, if there is valvular regurgitation, we will see on our phase contrast images that the flow changes in color. So here The white color indicates that the flow is going upward there in the proximal ascending aorta. But then later in the cardiac cycle, we see that it changes color, meaning that the flow is reversed. This is a patient with aortic valvular regurgitation. So we can calculate the flow above the baseline, and then the flow below the baseline. We can actually calculate the regurgitant flow here. And then from that, we can also calculate a regurgitant fraction. Now, we've talked a little bit about 4D flow, and with 4D flow, the idea here is to gather the information over an entire volume. And once you've done that, you can actually go back and interrogate particular regions of the vessels that you want to look at, and then look at flow rates and calculate all of that as you please. So for the rest of this talk, we'll talk about 2D phase contrast imaging. So here's a patient with aortic valvular stenosis, and then here is the phase image, phase contrast image, through that region. And now if we want to evaluate the severity of the aortic valvular stenosis, we can look at the flow profile, the velocity flow profile through that region. So here we can see the aortic valve itself maximally open. You can see there is aortic stenosis. But here from the phase contrast data, we can look at the peak velocity. And this is something that you do need to know. If you know the peak velocity, what is the equation for calculating the pressure gradient? And it turns out that that equation is the modified Bernoulli equation. So the peak gradient is 4 times peak velocity squared, where we express the peak velocity here in meters per second. So once you express that in meters per second, 4v squared, the answer then will come out in millimeters of mercury, and that is your peak pressure gradient. So here with a peak velocity of 3.5 meters per second, when we plug that into the equation, we get a peak gradient of 49 millimeters of mercury in this particular example. Now, another way we can evaluate the severity of aortic stenosis is actually looking at the valve area itself. This is called planimetry. So we look at the valve when it is maximally open, as in this example, and then we take an area measurement. So we trace an area measurement, and then our software will tell us what that area is. In this example, it comes out to 1.04 centimeters squared. And the valve area does correlate with the grade of aortic stenosis. I don't expect you to memorize the numbers here. Just realize that when the valve area is less than 1 centimeter squared, then you're dealing with pretty significant or severe aortic stenosis. And then here's an example of a patient with aortic valvular stenosis looking at the valve here with MRI. And you can see when the valve is completely open, it does not open all the way. And then we would take an area measurement when the valve is maximally open to calculate the opening area of the valve. Now, we also have various tables that can help us to evaluate the severity of aortic stenosis. Again, I don't expect you to memorize the numbers, but just realize that this data exists. So we have various categories: mild, moderate, severe, very severe, and we can look at peak velocity. You can look at pressure gradient. You can look at aortic valve area, and this will give you an idea of the severity of the aortic stenosis based on your MRI data. Indications for valve replacement: if the patient is symptomatic, if the valve area is less than 1 centimeter squared, or if the peak velocity is greater than 4 meters per second. And then the rest of these are indications for asymptomatic patients who might have severe stenosis, if their ejection fraction is compromised, if they're about to undergo other cardiac surgery, or if the peak velocity is quite high, 6 millimeters per second indicated there. Now, we also talked about the type of pulse sequences that we use for cardiac imaging. Usually these are SSFP, also called true FISP, and we compared that with the conventional gradient echo sequences, spoiled grass sequences that are used in body imaging. With these SSFP sequences, you get much more signal within the blood pool. So the blood pool looks brighter, more contrast between the blood pool and the myocardium on these sequences. These tend to use very low TR, very low TE values for these sequences, and the flip angle is 60 degrees as opposed to 20 degrees for spoiled grass sequences. But where the spoiled grass sequences might be more useful is when actually looking at the morphology of the valve, or to actually evaluate the valve. So your SSFP sequences, although usually they're good enough to look at the morphology of the valve, these spoiled grass sequences, they might sometimes give you better images in terms of the morphology of the valve or the anatomy of the valve compared to the background blood pool. So that is one area where you might use these if for some reason your SSFP images aren't giving you good enough images of the valve itself. So here's an example, somebody with a bicuspid aortic valve. So although you can make the diagnosis here with SSFP, with the spoiled grass sequence, it's much easier to see the morphology of that valve when it is wide open. Okay, so here's our next example. And here we see during diastole, there's a flow jet that comes back into the left ventricle. So this is a patient with aortic valvular regurgitation. And we also notice here on the images going through the valve that it is a bicuspid valve. These dark areas on the valve actually represent calcification. We also notice that there is also some aortic stenosis, as that valve is not opening all the way. So in addition to aortic stenosis, bicuspid aortic valve can also cause aortic valvular regurgitation. In this example, on these views, so here we have a left ventricular outflow tract view, and then here we have a view going through the aortic valve. We see that there is a flow disturbance here just above the aortic valve, but there's this large area of dark signal all on the aortic valve. Well, what could this be? Possibilities include, could be metal, right, from a valve replacement. Other possibilities, a blood clot. But this turns out to be endocarditis. These are vegetations. So vegetations on the aortic valve can also give you these areas of dark signal on our bright blood MR sequences. In our next example, we're looking at left ventricular outflow tract view. Again, we can see that there is flow jet here in systole above the aortic valve, so there is aortic valvular stenosis. Notice there's post-stenotic dilatation. There's also some dark signal on the aortic valve suggesting calcification, but we also have aortic valvular regurgitation. We can see a regurgitant jet during diastole coming down and hitting the anterior leaflet of the mitral valve, which is typical of aortic valvular regurgitation on these views. And then when we examine the morphology of the aortic valve in this case, again, we see that this is a bicuspid valve, resulting in both aortic valvular stenosis and regurgitation. Again, notice the dark signal areas on the valve, and these likely represent calcifications. Now here on our next case, now we have more extensive aortic valvular regurgitation. Notice the jet coming back into the left ventricle during diastole. So what is causing this? When we look at the ascending aorta here, notice that the aorta is dilated, coming down to the aortic root. This is an example of annular aortic ectasia in a patient with Marfan syndrome. So this is a nice tulip bulb sign here. So this patient has a dilated ascending aorta resulting in aortic valvular regurgitation. And then for aortic valvular regurgitation, there are also categories of mild, moderate, severe, and then based on your MRI data, you can calculate the regurgitant volume or the regurgitant fraction, and then from there you can correlate it with you can characterize how severe the aortic valve regurgitation is. Indications for valve replacement: if patient is symptomatic, if the regurgitant fraction is greater than or equal to 50%, or if the regurgitant volume greater than or equal to 60 milliliters per heartbeat. If the patient is asymptomatic and has severe aortic valve regurgitation, indication for surgery. If the ejection fraction is compromised, if patient is going to undergo other cardiac surgery, or if the left ventricular end systolic diameter there is increased. So here on our next case, we're looking at a two-chamber view here, and then here again is a left ventricular outflow tract view. So this patient has pretty extensive mitral valve regurgitation. So this is an example of mitral valve regurgitation this time. So the question is, how can we assess the severity of mitral valve regurgitation with MR? It's actually very difficult to directly measure in here because it's not like a blood vessel like the aorta where you get a very nice cross-sectional view of the flow. So evaluating this, we have to take somewhat of a more circuitous route to evaluate the severity of mitral regurgitation with MR. So how do we do that? Well, to do this, we need to calculate the stroke volume and the aortic flow. So the stroke volume we can calculate from our short axis images. If we take the difference in volume in the left ventricle between systole and diastole, that is our stroke volume. So that is all of the volume that is ejected by the left ventricle. So remember, with mitral regurgitation, that is going in two directions. So some of it will go in the ascending aorta and the rest will go backwards through the mitral valve into the left atrium. Well, if we calculate the stroke volume, and then we can calculate the flow through the aorta just above the aortic valve, if we subtract that from the stroke volume, then what's left over has to be the amount of the volume of blood that is regurgitating through the mitral valve. So in this example, the stroke volume was 129 milliliters. The flow through the ascending aorta was 78 milliliters, which meant that our mitral regurgitant volume here was 51 milliliters. And then from there, we can calculate a regurgitant fraction, which was 40% in this patient. So this is the flow curve through the ascending aorta, which we can derive from our phase contrast measurements here within the ascending aorta just above the aortic valve. Okay, so here's our next case. We have a two-chamber view here and a three-chamber view. And again, we notice that there is some mitral valve regurgitation. This time, see that there is a subtle backward bending of the mitral valve here. So this is a patient with some mitral valve prolapse, which is resulting in mitral regurgitation. And then for mitral regurgitation, we also have various categories, and we can stratify based on our regurgitant volume or regurgitant fraction. Indications for valve replacement: if patient is symptomatic with primary mitral regurg, if the regurgitant fraction is greater than or equal to 50%, or if the regurgitant volume is greater than or equal to 60 milliliters per beat. If the patient is asymptomatic and they have severe primary mitral valve regurg, if the left ventricular ejection fraction is less than 60%, or if the left ventricular end systolic diameter is greater than 40 millimeters. Or if the patient has symptomatic severe secondary mitral regurg secondary to some other problem like dilatation of the left ventricle. In this example, we're looking at a four-chamber view here: left atrium, left ventricle, right atrium, right ventricle. Notice that the left atrium is dilated. Here, when we look at the mitral valve, we see that the mitral valve is not opening all the way. There is this flow jet going into the left ventricle here during diastole. This is a patient with mitral valve stenosis. Also, we can see some pretty significant prolapse of the mitral valve, although we don't see much in the way of mitral regurgitation in this patient. So this is an example of mitral valve stenosis. So here in our next case, so here we're looking at the pulmonary artery. So here's the main left and right pulmonary artery. We notice a flow disturbance in the main pulmonary artery extending to the left, And then here on the sagittal view, going through the right ventricle and the pulmonic valve, here's the pulmonic valve. We can see doming of the pulmonic valve, and then here we can see this jet from pulmonary valvular stenosis. There's also poststenotic dilatation here of the main pulmonary artery. So this is a patient with pulmonic valve stenosis. This is usually a congenital lesion. Now for pulmonic valve stenosis, we can approach it very similarly to aortic valve stenosis here with phase contrast imaging. So we find the jet just above the pulmonic valve here, and then we measure the peak velocity through the jet, and with the modified Bernoulli equation, we plug that into 4v squared, the peak velocity plugged into here, and in this particular case, we get a gradient of 55 millimeters of mercury. And for pulmonic stenosis, again, we have various criteria, mild, moderate, or various categories of mild, moderate, severe, and these are the criteria for putting, based on the MR data, for classifying the particular patient into any of those categories. Now, this is a patient who had a history of repair of tetralogy of flow. Now, one of the problems here is that often the pulmonic valve is dysplastic and does not function well even after surgery. And so these patients tend to develop pulmonic valve regurgitation. You can see this patient has a dilated right ventricle. Even the main pulmonary artery here is dilated. There is pulmonary regurgitation here, even though it's not all that well demonstrated on these bright blue images, but notice there is no pulmonic valve. We don't see the pulmonic valve at all here. So there is pretty extensive pulmonic valve regurgitation. And then in this particular patient, on this 4-chamber view, we notice the right ventricle is dilated. Here's the tricuspid valve. Notice that there is also tricuspid valve regurgitation in this patient. Now for pulmonic valve regurgitation, so here are cross-sectional views through the pulmonic valve using phase contrast imaging here. These are the magnitude images. So here, notice that during systole here, during phase contrast, the color is white, but it is changing color. During diastole, it's turning black, meaning that the flow is reversing. So the flow is going backwards when it is turning black here. That's pulmonic valve regurgitation. So we can graph this. Here's our forward flow through the cardiac cycle. Here's our reverse flow. So the flow below the baseline is the regurgitant flow. So in this case, the forward flow measured 70 milliliters, the regurgitant flow 29 milliliters, so the regurgitant fraction here was about 41%. And again, with pulmonic regurgitation, there are various categories, and then based on your MR data, you can classify the patient into any of those categories of mild, moderate, or severe. And then not that I expect you to learn the numbers or memorize the numbers, but for patients who've had surgery for tetralogy of Fallot and who have developed severe pulmonary regurgitation, there are these criteria that they will use in the adult patients to replace the pulmonic valve. So if the right ventricular end diastolic volume index is greater than 150, if the end diastolic volume ratio, if that right ventricle is significantly dilated compared to the left ventricle, or the right ventricular and systolic volume index greater than 80, or if the right ventricular ejection fraction is lower than 47%, or if the left ventricular ejection fraction gets less than 55%. So these are all that criteria that have been described in the literature based on MR follow-up of these patients who've had surgery to correct tetralogy of Fallot, who then develop pulmonary regurgitation to decide when these patients need replacement of the pulmonic valve. So when the patient is young and when they have the surgery for tetralogy, they can't replace the pulmonic valve at that time because the patient will outgrow the valve. So when the patient reaches young adulthood, then at that point they can follow the right ventricular function with MRI to see if the function is deteriorating, or to see if the patient fulfills any of the criteria